And you watch the chat. If you can answer anything, simply answer as quick as possible so we don't. Well, welcome. I think we might have some more people joining, but we'll go ahead and get started so that we're not off track too much. We appreciate everybody taking the time today to join us. We will be allowing everybody to put questions into the chat. We won't take live questions today, and we will try to answer some during this presentation, but if not, we'll take them back and make sure they're available to the full group of those answers this week. We are recording this, and we will have it available on the website. So I think they'll probably be able to upload it in the mid to late week to have this available for others. We are trying to be as proactive as possible to help with the communication. So we're very encouraged to be able to kind of just walk through care planning, talking about care coordination and service coordination today. We will have more detailed information about HCBS waiver authorizations in a couple weeks, and we'll have that webinar posted as well. So while we may skim over some of those, we won't go into depth on that process. On this webinar, we're going to try to keep focused on care planning. Next slide. So today we're going to start and just talk about the pathway service and care coordination structure. We're going to talk about the care planning, and we're going to talk about our plan for pathways care transitions so that we can give you a baseline and have everybody make sure they understand what to expect in 41 days from today. Next slide. Go ahead. Next slide. So just some of you have already seen this, but we just want to kind of reiterate all of the pieces of our puzzle of pathways and the support that will be given to the different membership. We will have a enrollment broker. They have already been available, and we've already talked about that in previous webinars, where our enrollment brokers are available for members to triage through and to pick their MCEs and to ask questions on the different MCE services and their plans. Those have been active. And there we started enrollment broker letters in February. We started phone calls in March and April, and they did auto enrollment starting May 1st. And all members should be getting information packets on the MCEs that they are assigned to. And starting June 1st, all the MCEs will be reaching out to members individually, sending them welcome packets. We do want to remind everyone that the enrollment brokers are still available for those who have received a maybe auto enrollment and plan or picked a plan and would like to choose to switch plans. That is still available for any members as well. In addition to the enrollment broker, we will have a care coordinator assigned to every plan. The care coordinator is there for medical support. Not exactly, but it's more of the PA support, the traditional fee-for-service Medicaid support is what a care coordinator. They're looking at the big picture and they're making sure all the care components are taken care of. We also have a service coordinator. Service coordinator is what we currently utilize for our waiver needs or community support. We also will have assistance in navigating both Medicaid and Medicare benefits. So all the MCEs are required to have those people inside and available for their call centers to help members to triage through that coordination between the Medicare and Medicaid services. In addition to that, we have added another layer, and it's called a member support service vendor. So not only will you be able to contact the MCs directly and coordinate your benefits, but if there is any concerns or questions that you feel like are not being resolved, or you need that added support through the caregiving or regarding your MCs, we will have an independent member support vendor that will be through the state available to help members through this transition process and afterwards. And that is posted on the website, how to reach them, both the phone number and the email address for that. Next slide. So care coordination, we're kind of just doing a baseline. There is some changes with this. When we talk about it, we want to make sure you understand that all members, no matter what services they are getting, will be getting a comprehensive health assessment. What that will be done is that's our level of care. They will be able to go in and determine if they have needs and if they meet the level of care to qualify for NFLAC or HCBS services. Those care health or comprehensive health assessments will be done in person within 30 days of a member request on that. Members will also have alternative modes and different locations to be able to contact. They can get it by phone, or we are really trying to make sure that members have those care coordination support services. Other specific assessments that will be created and done for all members with NFLAC levels of care. We'll be getting a monthly loneliness assessment. They'll do a quarterly needs assessment. They also will have that annual level of care that is currently done for reassessment, and informal caregiver assessments. What the goal is that we will be trying to do added those touch points to ensure that we keep up on being proactive on what members need. Next slide. So what are we talking about this structure? We want to make sure that everyone knows that currently we offer patient-centered care coordination. This will just be strengthened within the MCE program through pathways due to the removal of silos between the waiver and the PA and Medicare. So they will be looking at the person as a whole. We're looking at all services and all care needs and doing planning and managing their health as a person in the middle, not just what services are available in each of the programs. So MCEs must at the minimum have 2 levels of care coordination. They'll have care management, which will be available for all members. That will be done by a MCE assigned care manager. And then they may have an additional care level of a complex care manager for those people that are in more high risk or high need areas. In addition to that, for members receiving NFLAC or HCBS, the MCs must provide a service coordinator in addition to the care coordinator so that we can make sure that we have the necessary support for members to get the needs they have. That will ensure that there'll be a both acute and primary and HCBS needs are addressed and coordinated between this care structure. Next slide. So who is a care coordinator? There's been some questions about who qualifies for care coordinator versus service coordinator. A care coordinator has to have a minimum of requirements here. So we have this, they have to be a registered nurse in good standing, or have a master's degree in social work, or a bachelor's degree in social work, psychology, special ed, or counseling, and have a minimum of 1 year experience providing care management services for individuals who are older adults or individuals with physical and developmental needs. Or we do allow for licensed practical nurses, so LPNs, with a minimum of 3 years clinical experience with adults. Those can be contracted or can be offered as direct employees to the MCs. The care coordinator would have a caseload no more than 50 members. Those would be adjusted based on how complex. So if they have more complex versus regular care coordination, there may be a lesser caseload based on each of those care coordinator. Next slide. So service coordination. So we left the care coordination, which is much more clinical. We're talking healthcare needs, and we're moving to the service coordination. Service coordination will also have a process of assessments and discovery and planning and facilitation. They'll be here for advocating and coordinating and monitoring the the environment, the social needs of the individuals, to supplement and to accent the care coordination that will be provided by the care coordinator. Service coordinator is responsible for developing and implementing specific service plans. In addition to a care coordinator, all members who determine nursing level of care, which is NIFLA, will receive HCBS and or institutional services, will receive a service coordinator to ensure and relate to the environmental and social needs. A service coordinator specifically will focus on supporting members to access long-term service and support, medical, social, housing, education, and other services regarding and help regardless of their funding source. So they are going to be looking at everyone for that. All members receiving service coordination will have a service coordinator who will work with the care coordinator and ensure holistic services are delivered. So we're looking at it as a whole picture. Next slide. So who qualifies as a service coordinator? We just wanted to make sure that we have a level set, the difference between it. The service coordinator shall be located in Indiana and must have one of the following. They either can be a registered nurse, an LPN, they can have associate's degree in nursing with at least 1 year's experience in servicing the elder adult population or disabled population. They could have a bachelor's degree in social work, psychology, counseling, genealogy, nursing, or health and human services. They could also have a bachelor's degree in any field with a minimum of 2 years full-time direct service experience with the older adult or people with disability. They could be a master's degree in social work, psychology, counseling, genealogy, nursing, and health and human services, or can have a associate's degree with a minimum of a 4-year experience with direct caregiving with the older adult or disabled. The caseload of a service coordinator is based on the number of members they service will be the maximum caseload they can handle. It would be 100 members available for their caseload. Next slide. So we want to just kind of refocus and reiterate how we view the pathways. The member is in the center. We're looking at patient focus, but they will be coordinating with both what we would consider the traditional Medicaid case management or case coordinator, as well as the Medicare care coordinator, case manager, and what we currently have as a waiver or MLTSS service coordinator. And all three are going to be in that communication to ensure members' cohesive patient-centered care is accomplished. Next slide. So let's talk about the service plan a little bit so that everyone understands what to expect with service planning going forward. So as I reiterate very strongly, our goals, we have matrix, we have quality measures that we'll be monitoring. We are really focusing on getting that integrated health services and delivering whatever setting that is best for the individuals to make sure the individuals' goals, values, and preferences are the focal point of our care planning. So we want to make sure we are looking at that as the member in the center and looking at all of those things, not only the health, but look at the cultural and social determinant factors and health equality. So we are looking at that and really focusing on seeing how we can best prepare and create services that will fulfill the needs, values, and goals of our membership. Next slide. So service planning. The service coordinator is required to initiate the written service plan, which addresses the member's LTSS and other needs during the first visit with the member. They will also combine the member's individual care plan, focusing on non-LTSS services, with the service plan to coordinate the member's full service planning process. And we are really focusing on making sure all of these meet the requirements of the federal regulations. So just as our demonstration in the bubbles next to it, we used to have as a service plan for the A&T waiver and a care plan for the PA, will now be that combination pathways care coordination plan. So we are going to be having not just separated, but they're looking at as a whole to incorporate that into one integrated plan. Next slide. So service plan continue. We just want to kind of tell you this should not be anything totally new. All these regulations and all these requirements are currently provided under the service plan. We're just broadening the scope to include the health as well. So what this service plan will reflect is the settings in which the individual resides or chooses for that individual. It looks at the individual's strengths and preferences. Also reflects the clinical and support needs as the individual goes through the assessment process for the functional needs. It also will be looking at the goals and desires outcome. So we're not looking at just what the today's need is, but we're trying to plan for the best outcome for the full individual. Well, we're really reflecting the services and support, both paid and unpaid support that is available for the individuals when we're looking at their goals and looking at what providers can be available. We do not want to disclose or exclude any of their natural support so that we can make sure that we can provide the best care and to focus on what they need and what the individuals would like to be able to do in their goals. We also be looking at risk factors and measuring to minimize them. So our goal is to not create a plan where the individuals are limited or set up as risk that could cause any problems. So we're looking at making sure there's backup plans and other strategies as needed to ensure that the individual has the care necessary in whatever setting they choose to live. We also want to very much understand what the individual needs, both in the service and support area, and to look at each individual's responsibility for and the entities or the provider's responsibility for monitoring the plan. So we're really going to be engaging our members in this process, and our goal is to have the members help drive it, but at the same time have input and creative solutions to best accomplish the goals available for them. The care plans will be available for the individuals. Each the member will be signing and agreeing to this care plan so that we're all in the same place and in there. And then we also will have it distributed both to the individual and other people involved in the care planning. So if you're one of the service providers, you will also be getting a copy of the care plan. Unlike when we've had the shift, the care plan will include all services. So if you're a provider providing one of the services available, you will also be aware of and know who the providers for other services that that individual is getting, because they will be also explicitly written on that care plan. Next slide. So just kind of this is a high level look at what tomorrow's service coordination will be. The MCE service coordinator will assess the individual for their needs. That service coordinator, as we stressed, could be internal service coordinator or an external contracted service coordinator through the AAAs and other independent care coordinating companies. At that point, they will assess the needs, then the MCE coordinator will develop that service plan. Currently, that needs assessment or level of care and service plan are done in conjunction. Those will be two separate steps going forward through the MCE program to ensure that we have that separation and that strength of touch points necessary to get that planning done at the level that we're looking for. That service coordinator will then send the referral to the provider. Providers will receive that NOAA to start the services at that point. And we will get into more details of how that communication is going to be, since it will not be through the current portal. Those will be distributed through the MCE's portals and be communicated out both through email and through the mail. Next slide. So the continuity of care and the continuation of services. We want to really focus, especially with HCBS providers, to make sure you're aware that the MCEs must honor the existing service plan for 90 days or until the expiration of the service plan, which then means that all service plans will continue after go live through this transition process. So if you are currently providing services for an individual, you will continue to provide services to that individual through the transition as the service plan stands today. So I know there might be some communication points and some questions about getting some of that NOAA information. It should be smooth, but we just want to make sure that everyone knows that the focus is to ensure service for the members is that continuity of care. They will have a service coordinator, a care coordinator is required and must have an initial face-to-face visit with every member in the first 180 days of enrollment. So they could possibly have a service coordinator or a care coordinator from the MCE or their current service coordinator visiting them as soon as July 1st in this process. But that does not mean they will be changing any service plans unless it's an increase in service plan. They will not decrease any service plan until after that 90 days. So they can't modify for that. So we want to make sure that service plans that are served as service authorization. So at this point, we want to make sure once you see that service plan, that is serving as an authorization through the transition process as well. Next slide. So collaboration, as we kind of really stressed, we're really looking for collaboration through this service plan. The service coordinator will collaborate with both the care coordinator and have joint discussions internally or and with the members to ensure that we look for that collaboration and looking for that to accomplish the goals of the individual. In addition to regular member contact visits, the service coordinator will meet with the care coordinator no less than one time per month to discuss those members' care. That could be a face-to-face, it could be a phone call. There is some flexibility on how that meeting is done, but they do have to have that care coordination contact and meeting at least once a month. In addition to contacts and visit with the individual members, we will also require any change of condition. They will be required to go out and do those visits as well. We also are requiring any changes that happen to their PDACs, and we will have ICT meetings and care coordination requests. So we'll talk a little bit more what an ICT meeting is. Those meetings are required on a regular basis, on a monthly basis for all of our members to do that coordination of care necessary at this time to discuss their current services and ongoing services and determine if there is possibly any changes where there need to be adjustments made to that service plan. The service coordinator also must provide the needed information and data exchange with HCBS and non-HCS services to work with the members. So we're looking at all services necessary for our members to be successful in the living setting that they have chosen. Increased complexity in work with the 3 MC process and the 3 systems could happen with the coordination, but we are making sure that they have that extra level of care transition people internally with the MCEs, as well as doing that transitions. If they are transitioning from one MC to another, we're requiring them also to have an ICT and other coordination mechanisms to ensure that continuity of care. Lastly, is all 3 MCs are also required to have housing coordinators and other care service coordination support knowledge internally, as well as they will be utilizing the AAA's community resource referrals as well. Next slide. So, interdisciplinary care team. Those of people who are the HCBS providers may already engage in this, but I know some home health are required to do this and Medicare companies are also required. So what is this? We are asking them to include all members who are included into the care of an individual, and they have to have these care coordination teams and communication between it. This opens up the communication both for the members, the care coordinator, the service coordinator, the Medicare care coordinator, if they have a Medicare coordinator, and all members relate supporting that member. So it could be an informal care manager or caregiver, or it could be a service provider. In addition to this, we also will be reaching out and making sure that they're talking to their PMP, any participating facility care coordinator, physicians, or any NP that they service. If they have physical therapy, occupational, we are incorporating all those, and there has to be that additional information flowing to this care coordination team so that that care planning is including all necessary needs. Next slide. So let's talk about the Pathways Care transition. We just want to kind of give you a high level of what to expect in this transition process. Next slide. So the state has currently received from our data and through the AAA information system and have been feeding to the MCs through this transition process. Prior to go live, all MCs will receive the member data. They'll get 6 months of claim data, they'll get diagnosis, they'll get the hospitalization history, they'll get emergency room history. They also will get information on existing care plans, the assessments, the level of care assessments. They also get copies of all authorization. So we are really trying to make sure that that MC will at least get the paper trail of all information that is around the current member, so that they have that background and history to make appropriate understanding of how to do that care coordination and service coordination. Next slide. So in this transition, what is the members going to have? The members will receive from the MC a member handbook and a welcome packet, so they'll have that. They will also be expecting an initial phone call. In that phone call, they'll be making sure that they clearly identify any language preference. It will also be introducing the care team that is available, giving them that contact point and touch point. I will also tell you how to reach out, as I said, to the care coordinator. It's going to hopefully be able to go through a full review of the service plans, also ask for upcoming appointments, talking about medication, and just to ensure they have a level set of the member needs and priority. These are touch points that are happening as this transition going. This will be in addition to or can be incorporated in both in person or by phone contact. each member should be expecting to receive both, not only a phone contact, but after go live July 1st, they should start seeing that there'll be in-person contacts for those assessments as well. Next slide. So care transition, what does a provider expect to see? So the providers will be, we'll do the continuity of care authorizations will start being received from the MCEs to providers starting July 1st. We're hoping that their systems can get it out a little bit before, but just so you know that the MCs will have that. It will be available through both in-network and out-network providers will see those authorizations, and it will be available on their network portals, as well as being communicated out, as I said, through via email and potentially through mail too. We're just confirming all of those contact points. Care coordinator will reach out to the provider to establish that relationship, to give you that contact so that you know who their care coordinator will be, or a contact person to know who to address or to contact to them if you have any questions or changes or needs in this transition plan. You'll get much more heavy contact after go live, but this is just our transition, and these will start as soon as June 3rd. They'll be starting these contact points. We also have ongoing provider engagement and communication. As we said, we have that interdisciplinary care team. All providers will be part of that, and it is required for them to be having that engagement with providers and communication with providers. Just so you know, as a touch point through this transition, in the IHCP portal, that is where you will see the MCE. So if you go in and do your regular checks and authorization, you will also see when you do that check which MCE was assigned for which patient that you have. So that is your place of location. Next slide. So this is kind of a high level, and it's kind of a lot of details, and it's a great resource to look at, but we kind of just wanted to show you what we consider the care coordination level of service journey for a member. So as you say, member will be enrolled in the pathways, MCE. The member receives the initial screening, stratification of care coordination levels to provide that information as they onboard into the pathways program after the initial transition. Members will then receive a complex health assessment that will determine their risk and to help the MC create that care plan. We wanted to make sure you understand that there are those 3 levels of care, what we consider the care management that's available to all members. That's assisting with everything from preventative appointments to access of care, talking about service coordination and everything from that standpoint. Then there could be those people who need more services or more care. And those are people that would be in the complex care management segment of that. Those people would be at high risk who need state-defined criteria. Those people, all services and benefits for the care management. It's complex care management. They will have those monthly touch points, both in-house, in person, or by phone. And these are people who do not meet the nursing home level of care NFLAC, so they would not be qualified for the HCBS services at this point. But then there's the people who are complex case management and service coordination. Those people who meet the NFLAC care level who receive that long-term services, and those people would be people that were currently on the waiver program or in a nursing facility. All people who are in there will get that complex care management. That means they'll also get that service coordinator as well as a care coordinator helping. They will be having those monthly calls and visits that are required. They will make sure that they have that whole patient-centered planning, checkpoints, and the reassessment and assessments that are occurring with that. So that's just kind of a nice overview of what we're talking about, what's going to happen with their care programming, or levels of care, and how this service coordination will work. Next slide. So I just wanted to kind of throw this. This is where we've had questions in the past. Where do we have these webinars and other educational points? If you go to that Indiana Gov Pathways, under the stakeholder engagement, you will see this webinar listed later this week, so that we want to make sure you know exactly where, because we've had multiple questions. Each of the MCEs will also be offering more trainings as well on their websites. So, but make sure that if you do have other people that will need this, or you would like to download the slides, this is where to go. Next slide. So we wanted to thank you for your time today, and we're hoping that this is kind of giving you a high level understanding of what our goals, what our intents, and what our planning is. We want to reiterate that we meet with the MCs multiple times a week talking about transition to ensure that everything we can is to make this transition period as smooth as possible. No one will be going without care. We're not reducing care at this point through the transition of the MCEs. What the goal is to get more coordinated care and to help members live in the setting and get the service support that they need to be as healthy as possible and productive. And I want to reiterate, I appreciate everyone putting in questions in the Q&As. I'm hoping that a lot of them were answered by the team. For those that we did not get to, we will be taking them back, writing up answers, and making sure that we distribute it to everyone on this call and have them available in FAQs. Remember,
this is we got a question about when will the MCE assignment be available on the IHCP provider site? Do they have to wait until July 1st, or will be up earlier than that?
They're already assigned. I don't know if they're uploaded.
It only shows the current date in the IHCP portal.
So it will be July 1st, but they will get the notifications prior to that from the MC. That's why we're having the MC reach out to all providers for that, available to know which provider they're with.
Perfect. Thank you.
And all of the actual members will have access to know who their provider is. So if you don't get a touch point as quickly as you'd like, that reach out to your members. They will have that availability to know who their MCE is, because they'll be not only getting that phone call, but they'll also be getting that welcome packet. And they should have already, or it just dropped, gotten a letter from the state notifying them of the MCE that they were assigned to or that they had chosen. We thank you for your time. As I said, we will be going over authorizations as well, because we know that that is a stress point. We will coordinate that on June 5th, I believe it is, but you'll see it posted both on the Facebook page as well as on the Pathways site. And we still encourage all of you to send questions to make sure that this transition as smooth as possible. But we appreciate everyone being understanding in the transition and knowing that their current service plan is not stopping. So even though it's transitioning from one system to another, you will still be providing care uninterrupted and will be able to bill and get paid for it after July 1st through this transition period. Thank you very much. Do you have anything you want to add, Kristen? And we hope you all have a great day.